And we are live.
Hello, everyone, and happy International Breast Implant Illness Awareness Day. Today has been a phenomenal day, and it's been so crazy busy for all of us, but I'm happy that we're here on this day to celebrate some of the many things that are going on in our community. And today we have with us Dr. Khan from Executive Plastic Surgery. We have Danielle Valoras and Terri Diaz from Breast Implant Health. And everyone mark your calendars because we are having another summit/symposium this year, and it's going to be great. So welcome everyone, and we're excited to be live.
Oh, thank you very much for having me. It's a pleasure for me to be on with you, warriors, the faithful, sincere force in order to bring awareness very assertively, very positively, and educating the many ladies who are not even aware of breast implant illness, and so that they can better their lives and their health, not only their lives, but the health of their whole families as well.
Agreed.
So I have my biggest question for you is, how did you get into the explant world, and what was your key turnaround?
So this is a good question. I just did a interview with a reporter from Austin, Texas, and this was the same question. And I get this question asked a lot. So I have not done a single augmentation. Excuse me, I've done only one on a cancer patient, but no cosmetic operation. I have only done one augmentation on a cancer patient, and she had the mastectomy, and I did reconstruction on her. So I chose very early, purposefully, deliberately, not to do what is the most common plastic surgery procedure done by a plastic surgeon, which is breast augmentation. A very quick operation does take 45 minutes to under an hour, and relatively very easy. And I knew very early on. So if you look at my training, I am a biochemist from the University of Texas at Austin. So I understood what is mass spectroscopy, NMR studies, along with the toxicity of, the many chemicals that we know of, along with the biochemistry of the metals, if you will. Now, when I was in my surgical training and we were doing mastectomies, we saw the many patients who came with the detrimental effects of breast implants, that is silicone rupture. Remember, in 1992, the silicone implants were banned. And so there were a lot of ladies that were coming forth now with the ruptured implants. And it was very interesting to see these ladies who were hurting, both cosmetic and non-cosmetic, that means the oncologic cancer reconstructed patients. And so I saw very early on the hurt that they were going through. And I told myself, when I became a plastic surgeon, remember, I have assisted and I have worked. The jewel of plastic surgery is augmentation, right? Breast chest reconstruction. That is well over half of what is plastic surgery, if you will. Now, plastic surgery has a lot of operations. So I said to myself, very clearly and definitively, I was not going to do a procedure that I felt uncomfortable doing. I did not want to do no harm. I did not want to harm any patients. And I did not want to do a procedure that only led to more surgeries and inevitably more problems. And so I said, I'm going to do all aspects of other plastic surgery, like leg reconstruction, for example, using Integra, burns, hand reconstruction, hand injuries, along with skin cancers, among the many others. And then my same patients came to me and requested that I replace their implants. And I said I was only going to remove them. And so then one patient after another, I always made sure that I would send the capsule off. And then I saw within the pathology, the many patients who were having the giant cell reaction, the histiocytic reaction, the macrophages, the foamy macrophages, the non-polarizable material consistent with silica. And these patients were, if you ask them collectively, well over 90% improving. And this is where, looking at the work that has been done by the many plastic surgeons where the capsules have been removed and the implants have been removed. And as reaffirmed by the manufacturers, the patients seek benefit from an explantation, and especially when the whole capsule is removed. So I started doing explants, and one of my patients who came to me from Arizona started doing this Facebook Live that we know of, that is the private breast implant illness support group page by Dr. Khan. And now I have well over 11,000 followers, and I'm not a social media person at all. I do not know how to do Instagram. I do not know how to do Facebook or YouTube. I still have trouble to this day. I would call myself like an old-fashioned doc. And now one thing led to another, and then I started explanting. I started doing more and more and more, and the next thing you know, this is exclusively my practice. This is all what I do. I remove saline, silicone, and residual capsules, and that is my practice. Now I actively talk about it, and I have done enough patients where last year in May, I have presented to the World Congress of Plastic Surgeons about my 1,000 explants, my findings, and how I choose to do it in a manner where when I look back at all of them, I can say that the take-home message is the whole capsule is removed and the entire implant and capsule is removed in what is preferably the end block fashion without the capsule left behind. So this has literally been a journey. No one taught me how to do an explant. In the 5 years of general surgery training that I did as a board certified general surgeon, the 2 years of research that I did, plus the fellowship in burns, plus the 3 years of plastic surgery training, no one taught me what an end block was, what 100% total capsulectomy. Actually, I had never done 100% total capsulectomy. But when I put the two and two together, and I must credit a lot of work done by the other plastic surgeons, such as Dr. Feng, Dr. Chand, and the many others who are truly the heroes when it comes to the war from 1992. When I use the word war, which means 1992, how they were removing implants, how they have been talking and publishing good data in regards to what is a proper explantation. We see the etiquettes of proper explantation. So this has been essentially my journey from the beginning to now. And I will tell you, in my wildest dreams, could I ever imagine that I would exclusively be removing implants for a living?
Wow, thank you.
Yeah, we're glad that that's the case. And I'm glad to hear you bring up the residual capsules that you're seeing, because this has been a very controversial topic, as you know, in the industry, in the patient community, in the plastic surgeon community. So we continuously see women who, maybe think that they're not getting better because their surgeon left some capsule behind. We've even seen doctors that aren't including that in their operative reports when the patients go to a different surgeon to have the residual capsules removed. But most importantly, the cancers that are associated with breast implants are known to develop in these capsules. So, I talked to most of the plastic surgeons that we work with, Terri and Danielle and I, they get it because, like you, they're doing a high volume of explant surgeries. And the more you do, the better you get at it. But it's really unfortunate that some of the leadership in the plastic surgeon societies are still dismissing capsule removal and end block and total capsule removal because, if these cancers are developing in the capsule, we have cases now where women are getting these cancers diagnosed after they have explanted and their surgeon left capsules in. So they're diagnosed a year later, 3 years later, a couple of them even 6 years later. And to me, personally, as a patient and a 3-time cancer survivor, that is very reckless and irresponsible. And, I do understand that not all surgeons are as skilled at removing breast implants and capsules because it is a highly skilled surgery compared to just putting implants in. But we would appreciate transparency from those surgeons. If it is out of your comfort zone, then send the patient to a different surgeon who's more comfortable and performs a higher volume of these explant surgeries, because it really is doing a disservice to the patients to leave those capsules in. And then, we have a lot of issues in the patient community with peace of mind. Women are asking surgeons to take pictures and videos of their surgery, of the capsules, because they want that peace of mind knowing they got everything out. Some of them have been sick for years. Some of them have been sick for decades. And so they deserve a proper removal, and they deserve to have that peace of mind. So
Sure, no, absolutely, very well said. This is the heart and this is what we're trying to do as far as raise awareness. Remember, there's two parts to this whole equation. Part number one, the surgeon must accept and overall wholeheartedly from his or her heart reaffirm the fact that breast implant illness exists. So that is 50% right there, meaning as far as the equation goes, to the point where the surgeon is not putting in implants, that automatically validates your plastic surgeon because it takes a lot of effort to say no to putting in an implant. Remember, in the time that it takes 4 hours for me to remove, I can easily put in 3 or 4 implants. So imagine I'm making 3 and 4 times as much if I'm augmenting, and much easier surgery. My back and neck would be a whole lot better. I will tell you after doing these quick augmentations. You know, I interviewed a plastic surgeon. He said it took 10 minutes each side to doing an augmentation. That's how proficient he got. So the surgeon should not and must not be augmenting in order for him to faithfully commit to saying that breast implant illness exists. Number two, he or she needs to have that Facebook, YouTube Live, or nowadays social media, or a check and balance by the patients, including myself, that there is complete transparency. The video pictures are there, implants are returned to the patient. So that's 50%. The other 50%, if your surgeon agrees to that he believes in breast implant illness, then he should and is capable of doing the surgery, because there are many surgeons who say, well, I don't believe in BII, but I will try to because you asked me if this is what it takes, sure. But when the going gets tough and the dissection is done on top of the rib, which is where a majority of the implants are below the muscle, that cauterization that essentially entails removing the whole capsule plus the fascia of the serratus anterior, pectoralis minor, the intercostal fascia, plus the periosteum, perichondrium, is what is required, not just cauterizing the tissue and saying, well, I just left that behind because it was dangerous and for the patient's own good, I just cauterized it or I left that 10% behind. That in itself will hurt the patient. So 50% is you have to be the believer in the manner I described, and the 50% you have to be able to show that you can and you have and you will do the surgery, because post-op, that peace of mind when the patient puts her head on the pillow that night, the 2 patients I did today, they have that peace of mind when they put their head on the pillow that their surgeon got it all out. And number 2, it was tested. So what you said is very important. The FDA, the plastic surgeons, and the whole medical community will accept that one fact, including the manufacturers, that BIA-ALCL is underreported. No one sends the capsules off to pathology, even the partial ones that are removed. And now the BIA, the breast implant associated anaplastic large cell lymphoma, is now missed, including squamous cell cancer, among others, which are underreported. And so it is imperative, very important, to send whatever is removed from the human body, i.e. in this case, the capsule plus an inflamed tissue, so that we rule it out and we have the peace of mind that it's not going to be a surprise later that lymphoma was found or squamous cell or other pathology was found.
Done. I'm happy. That is it. Why? Well, let me just take a breath. Speaking of pathology, how do you work with your pathologist? Because
very, very good question. And I will tell you, so as you see, we moved 3 months ago from our Novi location to right now at Bloomfield Hills. So I talked to the hospital, and with full transparency, I talked to the head pathologist, Dr. Imlay, you know, and again, just so that we're completely transparent with the discussion I had with him. And I told him every single sample must be tested for BIALCL with CD30 analysis. An active, direct discussion I had with him. He said it is unethical to do BIALCL. Some of my colleagues will find unethical to do BIALCL on every patient. And I thought that was a very interesting response by a pathologist, and very appropriate, because it costs extra, it costs more. And he said, if we see that it's normal pathology, why should we do the CD30 analysis? Because it's going to be more costly. I said, are you able to definitively, convincingly rule out BIALCL if you do not do the CD30 analysis? He said, no, we cannot, because the CD30 analysis, amongst other stains, are required to completely definitively rule out the BILCL. So he writes down now in every pathology report that the CD30 analysis was done, and it was upon my request. And yes, we don't. And then I asked him, how many times are you going to do the analysis without CD30 analysis, and you're going to potentially miss the BIALCL? Let's say even in 2 out of even out of once. I said, we don't want to do that disservice, because if you don't do the CD30 analysis, you're going to miss the BILCL because that's required, even though it might be exaggerated or overkill. Now remember, BIALCL is extremely rare of rare, but it is underreported. To date, if you look at the literature, there's only less than 1,300 cases reported in the entire world. But do you know how many capsules are sent to pathology? Only a fraction of a fraction. And that's why it's underreported, which is acknowledged by the FDA and acknowledged by the plastic surgeons. So anytime a capsule is removed, it must be tested so that the patient has the peace of mind that it was not the BILCL. It was not, believe it or not, breast cancer has been found. Fibroadenomas have been found. And again, these are the pathology samples that I've shared with my patients. So it is imperative that the CD30 analysis be done. And I have directly communicated with the hospital head chairman pathologist so that it is done in the manner that I request for my patients. And that is the bond that I have with my patients. So one of the samples, believe it or not, made it, and with full professionalism, to Quest. Now, Quest is a mega company with thousands of pathologists across, and they don't necessarily do CD30 stains. So the plastic surgeon must write history of breast implant illness, rule out BIA-ALCL, CD30 analysis, rule out malignancy, rule out abnormal pathology in those many labs that routinely would not perform CD. So you are communicating directly with your pathologist as a surgeon that I want you to rule that out, even if it's quote extra, because till you do the CD30 analysis, you're going to miss some, and we don't want to miss even one.
Agreed.
And well, CD30 is like a precursor, right? I just with a patient just this week, she went in and she had an explant, and she had 2 sets of textured implants in her history. And so we specifically asked to test CD30, and they said they would not, because one, the tissue looked inflamed, but okay, whatever that means. And then they also said that she did not have a seroma, so she didn't meet the precursors to allotting for the test. And it just was so infuriating to be met like that when all we want is peace of mind. And CD30 is a general, it's not specific to BIALCL, but
yes, it is not.
And so what would we find out as a community if we did test CD30 on everybody, smooth, textured silicone saline, and those who are with BII and or BIALCL? Maybe this is a precursor to know something about this whole disease process, or this whole silicone infiltration process.
Right. Now, I will tell you, from the many pathology samples that I've sent, one came back with a high T lymphocyte count, an aggregate and abnormal cluster of T lymphocyte. I sent the patient to Carmana's Cancer Center, which is the #1 cancer center, because you know what, as a plastic surgeon, this is way over my head. And you go to the specialists who deal with it, and you have to go to a major hospital institution that will have that personnel, not a small hospital in the middle of nowhere. Because remember, the quality control only goes down if you go to these quote small community centers. The point here is you have to test. If you don't test, you will not know. And that is as simple as, you cannot tell grossly by looking at a sample if it is or it is not. And the same thing, there are many reports where there was no seroma and the patient had BILCL. So a seroma is a red flag. Any patient who has seroma or fluid you have to always think, but doesn't mean that every BILCL has to have seroma. So this is not a question to ask, but this is where every capsule or tissue must be tested. And I'll tell you, in the world of COVID, where every single patient sometimes was getting a COVID test, or people who worked in the federal government got COVID test every day when they reported to work, money is not an issue. If you're the president of the United States and you're getting an explant, you're getting that CD30 analysis, whether you like it or not, and every patient needs to be treated like that royalty, that utmost care, so that we don't miss anything. And this is the problem. Everyone is downplaying it. It is so rare. The numbers are higher than what they're reported to be because of these overlooking and generalizing and saying it does not. The eyes cannot see anything. It's the microscope and the stains that will tell us everything.
Exactly. Nicely said. You know, it's very frustrating to be a woman who had breast implants and to know that the societies aren't for me, aren't protecting me. When you can see that even one person who has been explanted, can develop cancer in the capsule, and then you can, on the other hand, say, leave the capsules in, it's okay. Like it just is a mixed message in my head that no one woman or no one person should have to be subjected to any type of cancer. And we now know that breast implants, albeit rarely reported right now, result in cancer. But that one woman's family, that should be enough. That should be enough to say, okay, this is breast implant associated. This is breast implant associated ALCL. This is breast implant associated SCC. This is breast implant associated B-cell lymphoma, ductal cell invasive carcinoma, or there's a correlation to it, and breast implant associated BII, right?
Right.
It should be
So,
enough.
right. Now, absolutely, very well said. Now, the textured implants are notorious for the BIL cell, to the point where they have basically been essentially banned. There are smooth silicone and smooth saline implants, certainly, that have also been implicated, but to a lot lesser extent. The other thing I want to mention is squamous cell cancer was also highlighted by the FDA a couple of years ago. So that is to be taken seriously as well. And then, believe it or not, there are, and I'm not trying to scare, we know that there are other cancers that are associated that have not been fully established or studied, where we have yet to learn more about the other cancers that implants cause as a direct association of the implant and the inflammation that they cause.
Yeah.
Yeah.
Not to drive this home too deeply, but I know that if a tire goes flat in my car or on my car, I get a little warning light. And then when I bring it to the doctor, the car doctor, they know what to do and they know how to fix it. We're missing the warning light, and we have now, thanks to you. And I don't even know that, do we even have 10 doctors in the US that fully explant? I don't think we have 10. I think I can name maybe 5. I can name 5, right? So that know what to do when I bring my body into them. And so
No, I
how-
just want to mention, the BIALCL is relatively very rare. It is real, it is rare. The numbers are very low, but still, that what you said is that one patient, if that's you, that's like 100 to the patient, right? And so the point here is that it has to be tested, it has to be checked. Now, I say this to the world. If you are a surgeon, ENT, urologist, plastic surgeon, general surgeon, OBGYN, you remove any tissue from the body, it has to be tested, period. I will tell you a true story. One of my professors, and I am so honored to have the best professors from when I got trained in the Northeast to the Midwest. This is a real story. He was telling me back in the day, there was a surgical oncologist and a plastic surgeon. And he found that he was combing his hair and he started to bleed. And so the surgical oncologist asked his plastic surgery colleague, can you go ahead and just remove this so I don't bleed? And he removed it right after clinic one day. And back in the day, you could do these type of procedures like in the locker room. And, again, no, in the clinic at the end of the clinic. So they did it. 6 months later, it started to bleed again. And this time he sent that mass off, said, what is up with this? It's bleeding again. And it turned out to be melanoma.
Oh,
And the point here is another story. This is a true story. I took care of a patient. He was going to the podiatrist. He was a young gentleman with a non-healing ulcer. And they said, oh, it's just, you're diabetic. It's an ulcer. Don't worry. We're going to scrape it off and come back. And was not healing 3 months, 6 months. They did a biopsy. Turns out it was squamous cell cancer. The
Wow.
point here is anytime any tissue is removed from the human body, the standard of care, it has to be tested. Your eyes cannot tell. The microscope and the stains, and the pathologist who does 5 years of training is going to be able to stain it and say what it is and what it is not. And that way you have absolute confirmation that it is not cancer. And that, again, is that peace of mind that you have, that whole tissue was tested and it was not the BIHS squamous cell breast cancer. There are samples that I've sent to patients, and believe it or not, it came back as breast cancer in the capsule. And so this is where, had we not sent it, we would not have known. And so this is 101. There is no discussion, oh, it's going to cause more bills. That is not a reason. We have to rule that out. Number two.
and that's exactly what they say is, it costs too much. And then I looked at the capsule and it looked fine, so I didn't test it.
Right. Now, I will tell you, as I come here, there was a patient who said, and again, for me, I'm very transparent. When a patient comes to me, I tell them 100%, you're going to send the capsule off. Now one patient said to me, I don't want to incur the bill. She was an out of the country patient. She said, I'm going to accept my fate. And she wrote down and she gave me on the phone and in person consent that I do not want it to be tested because whatever it is, I will live with it. I don't want to give into the big pharma. And this was her very honorable excuse as to why she does not want to send to pathology. Now, I wrote it down, I document. I said, one patient, believe it or not, I felt so convinced that there was a problem. I paid for it. I said, we will incur the bill because I want to know what it is for the benefit of the patient after I got the patient's consent. The point here is that tissue must be sent and cultures must be sent so that we know. How many patients reach out to me and say, it's possible fungal cultures because I had a fungal infection. I say, till it's done, you won't know. And we don't want a big question mark afterwards, so that you want to get that complete, thorough analysis so that when you look back and you see you were treated like the president and you could not have done more, because everyone deserves the world-class care.
Yeah.
Dr. Khan, how do we empower those patients that go in to their plastic surgeon and say, hey, I watched this live and Dr. Khan told me that I need to get pathology, and they just laugh it off and they're like, no, you don't need that. That's just over precaution. It's so rare. So how do we empower those patients to ask for those things and demand them?
So I will say this, the biggest, I don't want to use the word poison, or the biggest obstacle is the surgeon's ego. And sometimes, and I say this humbly, the surgeons are a very assertive, strong, confident group of people. They didn't go into psychiatry. They didn't go into, pathology, where you have to be relatively passive, or radiology. Again, these are different personalities. Now, I will say this, the patient can ultimately.
Oops.
Oh, you're muted.
Confirmation and very professionally. Remember, anytime I approach someone or anyone approaches me, it can get very anxiety provoking but you go in with a clear, there is no other way except for finding out, and you understand, I just want to have that peace of mind that the entire capsule is tested, and that we know with confirmation that there is no chance. Believe it or not, one patient came to me And she brought a paper from MD Anderson and how you're going to blindly take 12
Oh, nice.
within that capsule. And I have to orient the capsule so the pathologist at MD Anderson will know exactly what the orientation is. So I told my patient, do you think I am doing my other patients disservice by not sending to MD Anderson? She said, I'll pay for it. I said, no problems. If you want me to send it, maybe I will learn something. I even called my head pathologist at the other hospital where I was at. He even talked to her and he did it exactly in the manner it was described. You know what? We will learn something. And he told me this is overkill. And I said to him, we just want to have the peace of mind because we will learn something from the paper from this patient. And lo and behold, the patient got exactly what she wanted and what I told the pathologist. And it was exactly documented in the manner that it was done, where the samples were actually sent physically, and an MD Anderson pathologist who did the paperwork, who wrote up this paper, how it should be done, did it in the manner that he describes to be absolutely thorough. And this is where, we have to be open to anything definitive. This is 101. This is no rocket science. So I tell the patients, no is not an answer. Number two, you have to request and the surgeon will send, because what is the reason why they're not going to send? Now, I will tell you, in the world of explant, many surgeons will not send the capsule because that in itself is proof. Because you can always go to the pathologist, look at the sample and investigate it as to what was done and how it was done and in the manner that it was removed like a wet tissue paper. You follow what I'm saying?
Yeah.
So they don't want to, so that in itself becomes proof as to how the supposed en bloc was done, because it was documented as such, but in reality it was not, because the surgeon forgot to take pictures. Now, I'm not trying to be mean here, but I'm just trying to say what happens, and it is what the patients have told me. So the patients should not accept no for an answer very nicely, very positively, very assertively, because we want to have that peace of mind. As the patients put their head on the pillow, they should have that absolute peace of mind that that tissue was tested for malignancy, cultures were done, and the entire capsule was indeed very much removed.
Right. I find it interesting that, we hear from the societies that the cost incurred is too much, but we also, from the patient perspective, there has been such a lack of accountability from the manufacturers. There has been such a lack of follow-up from the societies. No one's even registering patients, in the NBIR that was implemented in 2019. They're failing terribly at following patients. And if they really want to know, and a cost really is a problem, why aren't the societies putting pressure on manufacturers to pay for this? The manufacturers have not followed patients. They have all failed at following patients. And so if they really want to follow patients, let's test every patient. Let's see what's really going on. And the society should be backing that up and putting pressure on the manufacturers to do the right thing. What say you?
I will tell you this, if you talk to a lot of the plastic surgeons, they will say, well, implants are the most studied devices on earth. I will say this to them. Guess what? The implants were banned in 1992 for a reason.
Yeah.
So they are determined to be not safe. The gummy bear implants, for the many ladies who are listening and the significant others, gummy bear, just like when you eat the gummy bear with the ice cream, you can take a needle and poke it 20 times and guess what? There is no leakage. As you will see, many of my patients, when the implant ruptures, it disintegrates. It's like molten honey, it melts. And there is no such thing as a safe gummy bear implant, just like there is no such thing as a safe cigarette with a big filter on it. These are the same problems that we saw in the 80s and that led to the ban in 1992. The bond that holds it together, the cohesive, that's what they call gummy bear implants. They disintegrate just like the older ones. We have gel bleed that occurs in intact saline implants and intact silicone implants and certainly ruptured implants. And it's the same problem repeating itself. And so there is no such thing as I can drive my F-150 over the truck and look how safe these are. They are not lifetime devices. They will disintegrate. Look at the lady from the Midwest. her surgeon was pretty much absolute convinced that these are not ruptured, who was removing the implant under local. And to his surprise, the left breast implant was ruptured. And the next day or the same day, she saw silicone pouring out of her left chest.